All right, let's get started to respect everyone's time, and then Melissa, feel free to just let people in as they're coming in. So hello, welcome everyone. Thank you for joining us on this another very hot day. This is a very informal webinar because we're talking about informal caregiving, among other things. My name is Ilana Kiefer, and I work at the New York Academy of Medicine as the director of the Center for Healthy Aging. And I'm also on the steering committee for EmergingAging, who is hosting this webinar today. So to give you a little bit of background, EmergingAging was actually founded back in 2012 and brings together emerging and mid-career professionals in aging to learn about different trends and ideas in the field, to be able to network with each other, and also to work together to better serve older adults throughout New York. We are really committed to an interdisciplinary approach and to working with professionals across different sectors. And we have typically quarterly events, both in person and online, such as today. And as of last year, the EmergingAging became a program of the New York Academy of Medicine, so that we could become more formalized, and then also to be able to actually be able to raise money so that we can do the work that we do. And in that vein, we actually received our first ever grant from the New York Community Trust. So you'll be hearing more about that in the months to come as we plan kind of more robust events now that we have the funds to do so. And in addition, as I mentioned, EmergingAging is a program of the New York Academy of Medicine, where our vision is that everyone has the opportunity to live a healthy life. And our mission is to drive progress towards improved health through attaining health equity. And within the New York Academy of Medicine, we have the Center for
I bought that for Jake, right?
We're just gonna, Becky. We have the Center for Healthy Aging, which works to advance the health and well-being of aging populations through research, policy, and programming. And so we're really excited for you all to be here today. So in that vein, we are going to get our panel started in just a moment. Just in terms of housekeeping, please keep yourself on mute. We would love to see your faces if you are willing to do that. It's totally fine if you're eating lunch. We don't mind seeing that as well. And as I mentioned, because EmergingAging is now part of the New York Academy of Medicine, otherwise known as NYAM, we're also able to finally formalize membership by having membership dues. And so I'm going to put in the chat our membership link for that in case that is of interest to you. And I'll also put my email address. So if you want to ask questions about that, I am more than happy to answer those questions. We are going to have 3 panelists today that'll each speak for between 5 and 8 minutes. And then I have some set questions for them. And then we will, of course, turn to all of you for questions as well. The way we'll have it work is just put questions right in the chat. And then I will take whichever questions I like the best and ask them at the end. So we won't stop in between each panelist, just so that we can keep it moving. So if there are no immediate questions or comments now, which doesn't look like it, I just want to thank you all so much for being here, for spending your lunchtime with us. And I'm going to start with our first panelist. And that is, we are very lucky to have Marcella Goheen, and I'm going to tell you about her. So Marcella, during the pandemic, utilized her project management skills and founded EssentialCareVisitor.com for the essential care visitor who was separated from their loved ones living in long-term care facilities. Her widely publicized New York Times article about the vulnerable inspired the New York State's unprecedented Essential Care Visitor Bill, which was signed into public health law in March of 2021, signed by then Governor Andrew Cuomo. Marcella also received proclamation for her work from the Suffolk County State Legislature for her passion for the arts and community, and her disabled husband, a resident of a long-term care facility, recently received a proclamation from Mayor Attic Adams proclaiming July 1st, 2024, Robert Victor Viteri Day on his 70th birthday. Marcella, I hope I got all of that right. I'm going to turn it over to you to present about your experience as a caregiver.
Thank you so much for that intro, and thank you, Ilana, for asking me to be of service.
to this space, which I live every day. My name's Marcella Goheen, and my journey at being an informal caregiver began over 10 years ago with my husband, Robert Victor Viteri, who has now a day named after him in New York City, who lives with a neurodisease that has no name. And we, in our journey, went from Harvard to Columbia to Cornell to NYU to the University of San Francisco. Nobody knew what was happening with my husband at that time. So for 2 years at home, I caregived for him until I had to surrender him into a long-term care facility. And I always get teary. So the tears are joy and grief and all that complicated stuff that an informal caregiver goes through. And I caregived him through the COVID-19 virtually, which was an incredible, deep, still impacted trauma that I do believe and hope that our space of long-term care services and supports and our regulators will address at some point. So I also recently just put my mother, a 94-year-old, into an assisted living. So I'm living a double header. So my work experience during this lived experience focuses on formalizing the informal supports for the informal caregiver, if we cannot use that name enough, the word informal, so that the journey can be more joyful amidst the grief that is completely ongoing all the time, whether you're conscious of it or not. And I've always thought in terms of my husband's journey that from the get, it was an opportunity to grow and then to understand and to learn about the body and the mind amidst the grief and what's going to happen, especially with his disease that has no name and no doctor can figure it out. So we don't know the prognosis. We don't know how long he's going to live. We don't know any of that stuff in this neuro process that he's in. And I'm obsessed about the relationship that I have with this caregiving to him, as well as our relationship as a team, and how to better serve others. So that was a promise my husband and I made from the get-go. I'll never forget when we landed in his, what he calls his home and what I call his home, this long-term care facility in the middle of Manhattan. We went from a 10-bedroom house to a half of a room. So he has half of a room with a bed, and that was going to be our new life. And we looked at each other and he looked at me and he just started sobbing because this was not on our bucket list. But we fist pumped each other in that moment as well. And we said, well, you bloom where you're planted and you serve where God puts you. So here we are. And that's our family legacy. So, and that's the work in the space that I want to advocate for until the day he takes his last breath and beyond, is that this is a space that can be joyful. I've been torn at many moments between types of caregivers, the types of people that make a caregiver or not a caregiver, the people who understand, who don't understand, the data that's coming out, the truth about caregiving on a daily basis, and the lack of supports thereof, not just for me, but for him, because I do believe a happy caregiver, a happy patient is a happy caregiver. A happy caregiver is a happy patient, meaning we provide the systems of supports around the whole spectrum of the space. So for me, that comes from the front lines. So the formalization of the impactful supports come through one word for me in my experience, and that's community. If it wasn't for the 180 family members that I deal with every day at my husband's facility and beyond, where we interact with each other, we teach, we refer, we collaborate, I don't know what I'd do. And we're working 24/7 to formalize this space as the system works to recalibrate the transformative services that could be at play for this space to help everybody experience it better and give better services and supports to our loved ones who are vulnerable. So the slides I prepared focus on 3 things. What a caregiver might be thinking or experiencing at any given moment during a 24-hour period. I thought this might be helpful to the providers that are on, that serve informal caregivers and are working to serve them better. Also sort of the 3 pillars of practices that we use on the front line in our long-term care facility as a consumer that help us with the compounded isolation that could come up at any moment as we serve our loved one and feel like we're so alone and that who else is living this experience. And also the third focus is what not to say to a caregiver. I thought I'd just add some humor so you guys can understand when you're interacting with caregivers on the front lines, what not to say. So the first is just the title slide, is the truth about the informal caregiver. And then that's our website, which you can log on to anytime and see updates and et cetera. You can go to the next slide. So this sort of already reflects what I sort of already said about how it was when I first had to be thrown into the role as a caregiver, the relationship shift. I took it as an honor to this day. In my New York Times article, I that was the main part of my article, that I wish we live in a society where it's an honor and a joy and a privilege and not considered a burden. This whole idea of self-identification, which is something that came up a lot during the MPA in New York. I struggle with that to this day, about the implication of what is the benefit of self-identifying. How does that serving the space for me as a person on the front line? I just know it's, I'm my husband's wife. And I said that very vocally on the MPA, and it was scandalous, but I still struggle with that. That's the God honest truth. I'm my husband's wife, and I wish everybody was a caregiver who would have the instinct to make it a joyful space so that we can get the services and supports. I put family and friends, the way society looks at illness and death. That's a huge nugget of why I think the space is underfunded. It's because of our own societal consciousness that just not all of us are caregivers. My mother says, you're not Marcella, you're that person, and not everybody's that person, nor were they groomed to understand that. I was from the age of 7. So it's in my DNA. I just reiterate here the community and care. It's fluid, the community that we're in every day, serving our loved ones whose needs are changing. It's fluid, ever changing, evolving. So we always tell our family members, just stay in the day, take it one day at a time. Because if you start to project and go there or yesterday, or I shoulda, coulda, woulda, and then I wish I coulda, it just complicates the PTSD. And then I guess the last little point is the stigma of caregiving, from isolation to community. I have a whole new group of people in my life in the past 10 years that are my family, and we support each other every day, and it's made the experience incredibly enriching and inspiring and worthwhile. Next slide, please. So these are I threw words at the space because I wanted you guys to understand, if you're providers or you work in the space in a professional way, what any one caregiver could be going through at any moment in a 24-hour period. So I threw words out like traumatic, heartwarming, exhilarating, exhausting, frustrated, scary, hopeful, rewarding, all these words. But most of all, for me and my personal experience, it continues to be an honor. Just yesterday, I was helping another caregiver who has been taking care of her loved one at home for 23 years and had to do this care transition into a facility. Can you imagine being 23 years at home taking care of someone, being that person, and now having to transition the person? There's so much attached to that moment. So we were able to be there for her, because I know that moment. I know that moment where you feel like, oh, I failed because I'm transitioning them into an institution, when actually the institution is a great care partner for my husband and continues to be at this time. So my question here on this slide, and these are just prompts for you guys to think about as you move throughout your work, is how do we get society to understand this space as an honor so that it can be more robustly supported? Not just for the caregiver, but for the loved one, because the loved one is the one that's being served, and be a happy loved one who's getting their services and supports definitely makes our job easier. And also as well, I've always considered us the bridge care, because we as informal caregivers, we come in where those little times and spaces and the nuances are not being supported in the system right now. That's just age old. Like it's nothing new. It's just how can we now informalize those supports so that we can have a robust, healthy system of care. Next slide, please. This is the funny slide, the fun slide, which is the daily, and I know I'm over, the daily practices that we do on the front line. And again, my informal caregiving support is on the front line in an institution. We capture those moments when someone's just been put in the institution and we're there for them. Community, we each one teach one, and then we do care huddles. And then this is my pet peeves. This is the humor part of what I told Alana, I would say, based on my experience, is, we live as an informal caregiver in an incredibly complicated day where it's like, I call it compounded isolation, not because it's, everyone's going up to go to work and I have to manage my day based on like, okay, what does Bob need today? What does Bob need today? What's happening at the facility? Who's on staff? All these nuances. So, I don't talk to many people outside of our space that I'm living about, that I'm caregiving, because it's not helpful, because you get back this kinds of words. So these are the things you don't say to a caregiver. I'm sorry. That's not helpful. With that tone that kind of compounds the isolation and makes the caregiver feel even more like, oh my God, does anyone else care in the world? The other one that has been a trigger for me is he's so lucky to have you. He's my husband, and I'm so lucky to have him. And when we made that marital vow, I meant it. And that's not for me to be self-righteous or I'm better than anyone else, but I am so lucky to have my husband. And then the third one that was annoying at a church service when my husband started to get sick was there's just there's people who said, good luck with that, which as if it was like, good luck with that. It's like, good luck with what? Good luck with caring, good luck with loving, good luck with being a caring society where we do show up and we do and advocate and create innovative systems to fill those spaces of loving someone home is what I say, to whenever the body transitions into the other space and time, whatever you believe. So the last thing I'll just say is I do dream of a world where the caregiving role will not be a toiled exception, like, oh, she's a caregiver or they're a caregiver. Oh, that we have a common language to serve humanity in a kinder way for the aging and disabled populations. I did not know my husband to be he served the disabled in the New York education special ed for 30 years. I remember driving him to school and seeing those kids. I did not know this was going to be a part of our journey, but now that it is, I'm deeply committed to creating those spaces and times and structures so that this can be a common experience supported versus it being extraordinary and removed. So thank you so much for your time. And if my information's there and you can hop on our website and call me anytime. We'd love to talk about what we do all day long.
Thank you very much, Marcella. And next we have Laura Cardwell. Laura is the Director of Operations and Events at the Consumer Directed Personal Assistance Association of New York State, a membership organization that represents providers, recipients, and workers in the constantly evolving Consumer-Directed Personal Assistance Program, which she will tell you a lot about. Laura has served with the association since 2012, informing communities and families statewide about their choices in self-directed home care. So Laura, I'm going to spotlight you and take it away. Just unmute, yeah.
Right. Using Zoom is it's an evolving skill. So I wanted to first of all thank you for providing us with the opportunity to speak today on the Consumer Directed Personal Assistance Program. And I also wanted to thank Marcella for kicking us off and sharing your experience and getting to learn more about the advocacy that you have done on behalf of not only your husband, but everyone who finds themselves in a position where they need care and all the people surrounding them who love them. So I want to just thank you for sharing everything. So Alana, if you could go to, I believe, 2 slides ahead. I just want to give a brief overview of who CD Panties is and what the Consumer Directed Personal Assistance Program is and does. So CD Panties is a short acronym for a long name. We are the Consumer Directed Personal Assistance Association of New York State. Our organization has existed formally since the year 2000. It was originally a grassroots effort with a few disabled advocates from around New York State who wanted, there was discussion of needing to formalize advocacy for the Consumer Directed program. CD Panties is a disability-led organization, which means that the majority of our staff and our board of directors are people with disabilities, and many are people who they themselves use the Consumer Directed Personal Assistance Program to maintain independence in their communities for their day-to-day life. And Alana touched on this, but the role of CD Panties is to support CDPAP fiscal intermediaries and consumers statewide, as well as personal assistants who are the workers. Next slide, please. So I'd like to talk a little bit about and really define CDPAP so that we can all have a clear understanding of what it is. So CDPAP stands for Consumer Directed Personal Assistance Program. And this program has actually been around since 1980. It was originally a pilot program developed in New York City And the first fiscal intermediary was Concepts of Independence. So CDPAP came about as an alternative to the traditional medical model of home care, in which a person with a disability, at the time there was not as flexible of an option for them. So if you had Medicaid and you needed home care services, you sort of had to stay in your house and wait for the caregivers who were assigned to you to come. And then your care was performed in a way that was sort of prescribed from the top down to you. And the program was really formed as a reaction against, sort of that boxed in model. So it's unique in that it allows older and disabled New Yorkers to take charge of their own home care services. So in this case, taking charge means that the consumer, the person receiving care, is responsible for recruiting, hiring, supervising, training, and firing their own personal assistants, which are the people who work for them. And this is really freeing for people who, just a few examples. If you like to stay up really late at night and the home health agency shift of 9 to 5 does not suit you, then CDPAP, you can schedule your personal assistants to come, late at night. There are many, many examples that we'll touch on a little bit later. And CDPAP is a program that exists within the Medicaid program, and it is regulated by the New York State Department of Health. So that's the regulatory agency that has oversight of CDPAP. Next slide, please. So in terms of who is eligible to use the CDPAP, first of all, you must have Medicaid in order to use CDPAP. It currently does not exist within Medicare or within any private insurance options, although there are options available that are somewhat similar. But overall, long-term care is generally, your options are either to privately pay for it or to enroll in Medicaid and have coverage for long-term care that way. And when I talk about long-term care, I'm referring to somebody that has a need for 120 days or more of continuous care, and it's to address a chronic or permanent condition rather than something, for example, like recovering after a surgical procedure generally. So in order to use CDPAP, you must also live in New York State, which is because each state runs its own home care programs through their own statewide Medicaid programs. You also must be willing and able to self-direct your own services, which means taking charge of and assuming responsibilities over the people that you hire. But if you're not able to do that or not willing to, there is an option where you can have a designated representative who is willing to take on those responsibilities on your behalf. So with the inclusion of designated representatives in CDPAP, it has expanded the availability of the program to more people and a greater diversity of types of disabilities. And finally, in order to be eligible to use CDPAP, you need to have an evaluation done by the New York Independent Assessor, and you need to require assistance with personal care, home health care, or skilled nursing tasks as part of your long-term healthcare condition or disability. Next slide, please. So I want to talk a little bit about personal assistance. In this case, personal assistant refers to the CDPAP worker. Personal assistants must be an adult 18 years or older, able to legally work in the United States. And they're also required to have initial and ongoing health screenings as required by law. All of that is outlined in the personnel section of the law that dictates health requirements for healthcare workers in Medicaid. Next slide, please. And personal assistance, there are some limitations on who can work for you. So as it stands, the consumer's parent cannot be a personal assistant if the consumer is younger than 21. There was actually a lot of advocacy done leading up until 2016, when there was a change that allowed parents of adult disabled children to be able to work as personal assistants. Currently, the consumer's spouse is not eligible, so that provides a bit of a hole in terms of security for caregiving as far as married couples go. The designated representative, if the consumer needs one, cannot also be paid as a personal assistant because then you are essentially your own boss. And of course, anyone who appears on the Medicaid exclusion list due to any past problems with fraud, abuse, or other violations is not eligible to be a personal assistant. You know, the Medicaid exclusion list exists for individuals as well as for agencies. And, you know, I think that it's pretty straightforward not to commit Medicaid fraud. And, you know, we certainly don't want people with a history there to be in the programs. Next slide, please. So in order for personal assistants to be paid in the consumer directed program, they need to contract with an agency called a fiscal intermediary. So this is an organization that handles payroll, Medicaid billing, and administrative functions. You know, this could include benefits, you know, any kind of government, any kind of state mandated training programs such as sexual harassment trainings. And, you know, really a way to think about it is that your fiscal intermediary is like your HR department and the consumer is like the CEO. Fiscal intermediary takes care of, you know, a lot of the back end things that keep things running. The way that it works currently, New York state law requires that fiscal intermediary, you have to work with a fiscal intermediary in order to be paid through the program. And right now, consumers in the program have the right and the ability to choose and change their fiscal intermediary. So there are multiple fiscal intermediaries available to each consumer. And depending on what your priorities are, you know, some fiscal intermediaries work with specialized groups of people, have, you know, certain languages or disabilities that are represented. And they also currently offer different rates of pay and different benefits. So right now, as a consumer, you're able to have that choice. Next slide. So these are just a few examples. You know, these are based on actual people that I know, but I've changed their names, you know, by 1 or 2 letters. So the first example would be somebody who is a 37-year-old quadriplegic wheelchair user. He works, he likes to go on vacation, he has a girlfriend, and he has a very busy social calendar. So CDPAP makes it possible for him to do all of these things. And he hires male personal assistants who are about his age from advertising online because he's not, you know, he doesn't have any living family. And he, you know, he strongly would prefer somebody that is male and is not related to him anyway. The second example would be, you know, we'll call her Barbara, which, you know, I will admit that's my mother's name. Barbara is an 82-year-old retired person who has memory loss and some chronic conditions. So, and Barbara is not able to self-direct. So her daughter, Lisa, would serve as her designated representative. So Lisa, since she is the employer here, will hire her daughter, Julia, to care for Barbara so that Lisa can go to work and pay bills and make sure that Barbara and Julia continue to have a place to live and food on the table. And my last example is Sunan, who is 72 years old, and he needs help with his activities of daily living, but at this time he's able to make his own healthcare decisions. But Sunan recently moved to New York from Thailand, and he doesn't speak English. And this has made it really hard for him to access care through traditional agency programs where, you know, there are not large rosters of Thai-speaking home health aides. So Sunan chose CDPAP because this allows him to hire personal assistants from the Thai-speaking community, including a niece, and this can ensure that he can effectively communicate his healthcare needs. And next slide, please. And I'll just end here by providing a couple of resources on the program. So the first is a consumer resource center that CD Panties developed. And the goal of this is really to serve as a one-stop shop website to learn all about CDPAP. You know, it includes articles on how to enroll in the program, articles to assist you in managing personal assistance. And we have resources here in written, image, video format, as well as some audio recordings, because different people have different accessibility needs. And the second resource is our peer mentoring hotline. And this is a service that we've offered on and off since 2011, depending on grants, but, we have now established it as a permanent asset of the association. And this is free assistance from a consumer mentor. And so so it's an opportunity to speak to somebody who uses the program themselves. And this is to help new and experienced consumers alike manage their programs, answer questions that people have, and really go through a lot of the issues that are best handled by talking to somebody who's in your own shoes. An example of a peer program that comes readily to mind is, while it's very different from this, is Alcoholics Anonymous. It's really important to talk to somebody who has been there and is living this in their day-to-day life. So the peer mentoring hotline is free to anyone. So, I'm guessing that we'll distribute these afterwards, but, I'm also happy to take any, if anyone has questions about this, you can reach out to me directly. Alana provided my contact information. So that's really it for my end. I think I went over quite a bit, but thank you.
Very useful information, Laura. Totally worth going over the time. Thank you so much. And now for our final panelist, I'm happy to introduce Connor Callahan, who is the lead for family caregiving policy in advancing states, an association that represents the country's 56 state and territorial offices of aging and disability. In this role, he works closely with state aging, disability, and Medicaid long-term services and supports agencies, otherwise known as LTSS, conducting research and analysis of state and federal policies related to caregiving and the direct care workforce. And Connor is also on the steering committee for Emerging Aging. So Connor, I will turn it over to you.
Thank you so much, Ilana. Thank you to Emerging Aging and to Marcella and Laura for their excellent presentations, really highlighting the two essential components that move the needle forward in an underfunded area, and that is advocacy and innovation. Just a quick note about Emerging Aging. So I've been involved with the organization since the winter of 2023. And the value for me was when I was living in New York City, everyone seemed to be working in entertainment or finance or hospitality. And I would tell people that I worked in aging and what I did, and I would get blank stares. So it's a really great place, to have this space for folks in the field of aging, which will only grow in the foreseeable future, where we can gather and network and learn. As Alana mentioned, I am the lead for family caregiving at Advancing States. We were founded in 1964, the year before Medicare, Medicaid, and the Older Americans Act. We were known as the National Association of State Units on Aging for most of our history. We are a national nonpartisan organization, and as Alana mentioned, we represent all 56 state and territorial agencies on aging, disability, and many of our members are Medicaid LTSS directors and their staff. I'm going to say LTSS instead of Medicaid long-term services and supports because I will get tongue-tied. LTSS, so these are the programs that serve older adults in different settings and people with disabilities in different settings. We also host the only national home and community-based services conference, which draws over 1,500 attendees over 4 days. This year it will be in Baltimore. Our vision is here on the screen. I'm sure you've had a chance to read it. More info can be found at advancingstates.org. Please, next slide. So just a few minutes to give you a national overview. So I thought I would start with Alabama and work my way through the alphabet. I'm just kidding. We're not going to do that. But I do want to make a note about the language that I'm using. So I'm going to use the term family caregiver. It's the term that I'm the most comfortable with. It's also the term that the Administration for Community Living, so the federal administration that oversees aging and disability, that they use. And that a note about this definition is they encourage it to be used in the broadest possible sense. So they define family as spouses, partners, children, siblings, friends, neighbors, kin, cousins, nieces and nephews, grandparents, parents, godparents, and others. And states may employ more narrow definitions of family caregiver for their services. Next slide, please. So this next slide, there is a lot of information on this infographic. My intention is not to overwhelm you. Sorry, next slide, please. but we're currently updating this. The data is a little out of date. For example, if you see in the bottom right-hand corner, the estimated value of unpaid caregiving today is actually more than 600 billion, that's billion with a B, rather than 470 billion. Considerably more than the cost of Medicaid long-term services and supports, which is the most expensive part of Medicaid. So I just want to leave you with 5 or 6 key takeaways. And the first is that Americans overwhelmingly wish to age in their homes. So we want to stay at home as we get older, rather than ending up in an institution. It's important also to note a lot of Americans have a fear of ending up in an institution. Only about 3% of folks do. So experiences vary. But this means that we will have to rely on family, friends, and neighbors in order to do so, in order to age in place. Caregiver supports are associated with improved health outcomes for caregivers themselves and the folks that they care for. 1 in 7 Americans is a caregiver for an older adult or a person with a disability. And what I want to emphasize, and what the national conversation should be about caregiving being treated rather than a risk, but as an inevitability. Former First Lady Rosalind Carter has a great quote. She passed away late last year and was a huge advocate for caregiving. And she said there are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. We do not like to think about having to be caregivers, however. Another key takeaway is that demographic changes, including an aging population, lower birth rates, greater workforce participation among women, and varying immigration rates will have significant effects on the future of family caregiving in America. You can see here that women are more likely to be family caregivers than men. They are much more likely to be family caregivers of people with complex care needs, and more likely to be experiencing what we call sandwich caregiving. That is taking care of maybe a child under 18, as well as an older relative or a person with a disability. And many of them also while working full or part-time. We're also seeing more youth caregivers of older adults, something that we refer to as kinship caregiving, that is grandparents or other relatives besides parents raising grandchildren. And here we have an interesting, a dynamic of a young person being a caregiver for an older person who is also a caregiver for them. So no 2 caregiving experiences are alike. A third point I would like to make is that Medicaid is the primary payer for LTSS that helps adults and persons with disabilities live independently. So because of this, unpaid family caregivers are going to be increasingly a crucial component of states' efforts to control Medicaid costs while also providing quality for their residents. Public funding for caregiver supports is inadequate. This is another key takeaway. Medicaid and Medicare, except in limited circumstances, do not provide direct supports to family caregivers. This comes as a shock to a lot of folks. There are no direct supports for family caregivers, or very limited direct supports for family caregivers in Medicaid and Medicare. This makes, folks have to rely on private pay or private insurance, or to build a caregiving team that can, or do it alone, which, as Marcella noted, can be very lonely and bad financially and physically and mentally for family caregivers. As Marcella also said, happy and healthy caregivers equal happier and healthier care recipients. The research bears this out. So this is really important for states and the federal government to understand. 5, there is a strong bipartisan support for caregiver initiatives among the electorate, and voters rank caregiving issues as high importance. Recent polling found that 70% of voters 50 and older are more likely to support a candidate who backs proposals to support family caregivers, such as tax credits for caregivers, paid family leave, and respite services. And finally, supporting family caregivers is a way to help address the nationwide, in every single state, the nationwide emergency workforce shortage among direct care workers, so the paid caregivers. Family caregiver well-being is inextricably linked to the improvement of conditions, pay, and career pathways for paid caregivers, as I mentioned, also known as direct care workers, or in the intellectual and developmental disability space, direct care professionals. So policies and programs that strengthen and support direct care workers also strengthen and support family caregivers, vice versa. Next slide, please. I won't be able to spend too much time on paying for caregiver supports. Again, the key takeaway here is that public support is minimal. What caregiver supports does look like is training, individual or group counseling, respite, that's somebody to give you a break from your caregiving duties. This also might look like adult day, so a place to take a care recipient, and even payment. Again, huge caveats about Medicare and Medicaid. Only in very limited circumstances are there direct caregiver supports through those programs. But I would like, if you'll notice, so Older Americans Act, Medicare, and Medicaid are all Great Society programs. All of them debuted in 1965. And the Older Americans Act is very lofty goals, and its intention is that for all older Americans, all Americans over 60 and their caregivers, to live and age with dignity. So it is not means tested. You do not need eligibility. Anyone can access services. Older Americans Act, or OAA, funds things like nutrition programs like Meals on Wheels, some senior center services, transportation, and then about 9% of the funding goes to caregiver supports. The whole program is funded at about $2.5 billion a year. For some perspective, Medicaid is about $750 billion, and Medicare is also about $750 billion. So very little funding for Older Americans Act. States match and supplement OAA dollars with state dollars. Some of them do generously, and some do not. So it really depends on which state you're living in. So as Laura mentioned, each state gets to tailor their Medicaid program to their residents. Medicaid for LTSS, for long-term service and sports, by far the most expensive part of Medicaid. It serves about 4% of the population, but is between 1/4 and 1/3 of the Medicaid budget in most states. Some states have begun offering services directly to caregivers. Washington, California, Oregon, Arkansas come to mind. And many states used American Rescue Plan Act funds to support family caregivers. And as I mentioned before, research bears out that social supports supporting families are associated with better health for Medicaid recipients, so associated with lower emergency room admissions, for example. And very recently, only due to the COVID-19 pandemic, Medicare began offering training for caregivers. It is very limited. So the public options are not optimal. Managed care organizations like Molina, Humana, so these big health plans, they offer caregiver support. And then employers also can offer good family caregiver supports like flexibility in working, working remotely, or flexible time, and some other caregiver supports. Next slide, please. The final thing I want to talk about today is the national strategy to support family caregivers. This thanks to the activism of family caregiving advocates. There were 2 congressionally mandated councils that recommended the creation of a national strategy to really put everything together and to create a blueprint for the nation so that states and the federal government and local entities can work together. It was published in 2022 by the Department of Health and Human Services through the Administration of Community Living, and it contains hundreds of actions that are already being taken by federal agencies and many, many recommendations for states and local entities. It is, however, not funded. There are no appropriations for this, or there are very, 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 very little. So it's a blueprint. It's a nice index of possibilities, and I will share the link to the national strategy. So it's kind of similar to, in some respects, aspects of a multi-sector plan on aging, a blueprint for the future. And so finally, I'll just share a few resources because I know we're getting low on time. I had some examples of some innovations that are happening in other states. So like New York with CDPAP, other states have consumer-directed programs, but also offering things like caregiver tax credits, something called structured family caregiving, caregiver consultants, so that you can meet one-on-one with someone to help you with your caregiving journey. I can be reached at ccallahan@advancingstates.org. And I'm going to share some resources in the chat. But other than that, that is my spiel for the day. Thank you very much for having me.
Wonderful. Thank you so much to all of the panelists. Missy, you can stop screen sharing now. And I'll just ask the panelists to unmute themselves. There have been lots of questions in the chat, so I want to thank you all for that. There were two people asking to Marcella about what are some supportive things that people can say to informal or family caregivers. Marcella, you're on mute.
Yeah, sorry about that. My experience has been, if you yourself have never been a caregiver and you were learning that your friend is a caregiver or something, there's a shift, I would encourage you to familiarize yourself as a friend action to the supports that might be out there for that person, because when you're in the middle of it, you don't know where to go, you're stressed out, you're hysterical, you're all over the place, and the last thing you're doing is research. You just need someone to tell you. So that would be helpful. And things like you're doing a great job, or you can do this, or you're doing enough. Because as a caregiver, we never feel like we're doing enough, because I think at the bottom of the whole thing, we just wish that someone wasn't having a disease in the first place. So, and most often people say, or people never say, if you ever need anything, let me know. Because if they do say that to you, they're never there when you call them. So it's interesting. But one of the biggest things you could say as well, if you are an informal caregiver, that's so helpful that we say to each other all the time, all day long, on the front lines in institutions, in an institutional setting, because it wasn't there in the home setting because you're all alone, but with the home setting with your caregiver, it's very isolating. I'm not a popular belief system on that front, I know, but if you're in an institution, we say, I get it. Me too. I've been there. That's so helpful. Thanks.
Great, thank you. And thank you, Laura. I saw that you very thoroughly answered the question about kind of CDPAP versus home care. So we'll move on. Feel free to keep putting questions in the chat. I also have a couple of questions. I see actually we have at least one person who works for the New York State Master Plan for Aging. So I just want to kind of hear from all three of you what your involvement has been with the Master Plan for Aging, and kind of or how your field is interacting in that planning process. And for anyone that does not know, it is the Master Plan for Aging is a process that many different states have been undergoing over the last several years to develop a 10-year plan for states to address aging and caregiving needs. And New York is in the process of developing that plan as we speak. So why don't we work backwards? Connor, do you want to talk first?
Sure. Thanks, Alana. So we recently conducted a survey of our members who are the caregiving policy leads in the 50 states. We've reached about 36 states so far, and we've asked them this question. So how are family caregivers being involved in the multi-sector plan for aging if they are conducting, or if they are building a multi-sector plan? So a multi-sector plan, if the idea is like collaborating across agencies like health and labor, right, in order to tackle the future of aging. And by and large, all of them were involving family caregivers at some part of the policymaking process. And it's interesting, this conversation came up with, for example, I was a live-in family caregiver for 4 years, and it also really kind of like changed the way that I thought about caregiving. But having kind of a formalized presence of family caregivers in the policymaking process, that is, so family caregivers review the plans. They also will be involved in the state plans on aging, which states have to come up with every few years as well. And each state plan is different. So California, California's multi-sector plan, their first pillar is housing. But another one of their pillars is caregiving. So each state gets to tailor, to their own needs. But we are seeing family caregivers, by and large, included in the policymaking process. Now, what that will actually look like, is it pro forma? Is it just like, oh yeah, we had a family caregiver review our, or are they more directly involved in the process? That's to be seen.
Yep, that makes sense. Laura?
Sure. So I personally did not have a whole lot of involvement in the master plan for aging, but our director, Brian O'Malley, was a participant on on that work group. And I think that it was a really good opportunity because oftentimes in discussions around aging and in caregiving, we always complain about how everything is so siloed because different programs do their own things and then they don't all necessarily talk to each other. So I think the master plan on aging was a good opportunity to get a lot of different perspectives in the room and, really increase understanding between different participants about, what the other people are working on. So, I think that was really beneficial. And I'm interested to see, what the results are.
Yeah. And Marcella, you and I met on one of the subcommittees for the MPA. So can you just talk about your involvement?
Yeah, I sat on 3 different committees: the long-term services and supports, care transitions and system navigation, the informal supports, and my favorite one, believe it or not, was the cognitive health one with all the doctors, because they were very interested in figuring out how to serve better on the front line. That moment where someone begins to have a cognitive impairment and how that could be served better. So I believe that the experience showed, just like Laura said, that there was a lot of people doing the same thing, working in silos, trying to solve the one major problem within each space. And I, the preliminary report isn't out yet. It's supposed to come out mid-July, but I'm hoping that at least some of the recommendations, might stick, because there was definitely a deep dive done. And the consumer voice, like I think in the informal caregiving, I was one of the only consumer voice. So it was very interesting to hear, I guess I don't have a word for it, but it was very interesting to be that voice and to be, one representing many versus, and being not considered anecdotal evidence, because there are so many people that don't have a voice and they don't have people speaking for them. So there's a whole plethora of people who aren't documented at all, ever, and will never be. So we use that in the nursing home setting where they always want you just focus on Bob. No, Bob represents everybody, because there's 800 people that don't have a voice and they're just going to wither away and die. So, which, yeah, it's a horrible way to say it, but you know what I mean? That don't have the dignity, the aging with dignity, that we're all working toward, which every human right has that. We all have that right to be served with dignity, no matter what life form we're taking. So thanks. I don't know if that's helpful. We'll see what happens. Hopefully some of the innovation will stick and hopefully it'll be funded. That's a big cry for some upstate lobbyists.
Yep, absolutely. Thank you. So our last question is kind of a challenging one, but it's obviously hard to avoid politics and the upcoming presidential election. So my question for you is, there will be another presidential debate. So if you were a panelist or a moderator at that debate, what question would you ask related to the topic that you spoke about today? Anyone can start.
Sure. So with over 50 million family caregivers and a majority of them working full or part-time, what are you going to do? What is your plan to support working caregivers? Caregiver supports are associated with lower turnover, absenteeism, increased economic productivity, and decreased healthcare costs. So what is your plan to support working caregivers?
Very good.
And I would not want to ask that question at this.
Understood. Who's next? Marcella?
My big question would be, what master plan are you going to design to address the ever-growing dense population of the aging that are going to need long-term services and supports? In New York, it's 5 million that will be over the age of 65. Thank you, Becky Prevey from the Aging Association of New York. That will need long-term systems and supports in 3 years. What plan do you have that above and beyond the master plan for aging, are you going to normalize that data and serve the aging and disabled population in a way that's kind, dignified, and supportive to their maintaining the highest level of functioning, which is their human right.
I mean,
So this is kind of a tough question to answer because I would have so many questions for, you know, this theoretical presidential debate. But you know, I would be really interested in addressing, because, you know, I would really like to ask them, you know, as somebody who is the age that's often considered to be the sandwich generation, you know, my peers are starting to raise their own families while also needing to handle caregiving responsibilities for parents. Do you have a plan that would involve reformation of Medicare to begin to wrap in a long-term care benefit? Because just anecdotally, the majority of people my age assumes that you turn 65 and Medicare will take care of everything. And so there's a growing chasm of people who can afford private pay care for everything, and people who need to exhaust all their resources and then apply for Medicaid. And then every single state identifies Medicaid spending as like the big problem that is ruining their budgets every year. So I would be interested to know, you know, if the president would be willing to work on a plan that would really change how the whole system works, because it's being over labored. And I just don't think it can continue the way that it is.
no. Thank you all. And I just want to note Marcella's lovely comments in the chat about creating joy. I think that's like a really nice place to end on. So we are going to wrap up. I want to thank my coworker Musa for his behind the scenes work on today's webinar. And I also want to acknowledge Connor, Tega, Ilana, and Kristen, who are all, plus me, plus another colleague, Allison Cook, make up the steering committee for Emerging Aging. And really want to thank each of the panelists for sharing your work and your stories and continuing the important work that you were all doing. And of course, thank you to all of you for joining us today. I will send out the slides and all the different resources that were discussed. And we hope you'll come to a future Emerging Aging event. Have a lovely rest of your day.
Thank you. Thank you very much.
Thank you.
Thank you.
Thank you. Thank you, guys.